guys, so it is officially 8 o'clock Eastern Standard Time. So we are going to go ahead and kick off the first For the Breast of Us webinar. We're so excited to be doing this with you guys. We see you, Dante. Dante just left a comment to let us know. I'll let him know that we can see him. There's Dante. We are super excited to present Your Body, Your Choice tonight, a webinar that's about shared decision-making for women affected by breast cancer. Tonight, we have some incredible guests to go over breast surgery and reconstruction, clinical trials and medical research, and also infertility and fertility. My name is Jasmine Souers. I am co-founder for the Breast of Us, and I am here with my partner, Marissa Thomas. Say hi, Marissa.
Hello, everyone. Thank you for joining us this evening. We are very excited to have you here, and I hope you learn a whole bunch and have a whole bunch of questions for our experts and ourselves once we get started.
So, shared decision-making is really important to us and also for communities of color. As you guys know or may not know, For the Breast of Us is a community for women of color affected by breast cancer, and women of color, specifically African-American women and Latino women, we face some pretty harsh disparities. Some of that is part of communication and understanding and not knowing that we aren't being presented with options. So tonight, we're going to give you guys a chance to talk with some expert about some of those options, to ask some questions, and then give you some things that you can go back to your doctors and discuss. So Marissa, explain to us what shared decision-making is and why it's important.
So shared decision-making is a key component of patient-centered healthcare. It is a process in which clinicians and patients work together to make decisions and select tests, treatments, and care plans based on clinical evidence that balances risk and expected outcomes with patient preferences and values. So in many situations, there is no single right healthcare decision because choices about treatment, medical tests, and health issues come with pros and cons. Shared decision-making is especially important in these type of situations, like breast cancer, for example, when there is more than one reasonable option, such as screening or a treatment decision, when no one option has a clear advantage, when the possible benefits and harms of each option affect patients differently.
Yes, and so some of the benefits of shared decision-making is one, that it allows patients the opportunity to understand the process that they're going through. It also builds trust between patients and their doctors. Research also shows that patients tend to choose the less invasive and less cost or more cost-friendly option when they are presented those options. So tonight is really about informing women and making sure that they can make all the decisions that they want to about their body. Hence the name, Your Body, Your Choice. So our first guest tonight is Dr. C. Dr. C is a board-certified plastic surgeon, breast reconstruction surgeon, and microsurgeon, and president of the PRMA Plastic Surgery in San Antonio, Texas. He specializes in state-of-the-art breast reconstruction with a particular focus on the perforator flap. How do you say that, Dr. C?
Perforator flap.
Perforator flap, breast reconstruction, nipple-sparing mastectomy, techniques to maximize aesthetic outcomes, and restoring sensation after mastectomy. And that's a big one, ladies. Dr. C has dedicated his professional life to advocating for breast cancer patients. He strongly believes that shared decision-making between the physician and patient is crucial in achieving the best outcomes, and has built his practice on this philosophy. To empower as many patients as possible to advocate for themselves, Dr. C has created the Breast Advocate app, a free app that provides anyone with a breast cancer diagnosis or an increased risk of developing breast cancer a much needed voice in their breast cancer treatment planning. Welcome, Dr. C.
Hi, thanks for having me.
Thank you. So we're going to jump right into some of the questions that came up that women submitted. And this one has been a hot topic. Marissa and I had the pleasure of going to the San Antonio Breast Cancer Symposium. And this idea that women didn't need to go through mastectomies all the time, that we were going through these very invasive surgeries unnecessarily, research has shown that there is no added survival benefit to getting a mastectomy versus a lumpectomy. But fear of recurrence isn't the only thing that women should think of when they're deciding if they want to do a lumpectomy versus a mastectomy. For me, I also consider like the size of my breasts and if my doctors would be able to actually match them. What are some factors you think women should think of when they're getting ready to make such a big decision?
Well, the factors that are personally important to them, which is unfortunately, those are the factors that as physicians tend to be ignored. There's no doubt, there's no survival benefit from having a mastectomy when compared to lumpectomy and radiation. Some studies have actually even shown now that in some cases, the improved survival, long-term survival, is associated with breast conservation, with lumpectomy and radiation. And we think that's because of the protective effect of radiation on future lesions. So there's even more push now to really, to be honest, push women away from mastectomy. It is seen as very invasive. The problem is that the conversation is limited to survival, and it's not just in quotation marks about survival, because the consequences of the decision making is what women who survive longer have to live with.
Absolutely.
So the factors that are important to individuals, unfortunately, doesn't make the conversation very often, and this is where shared decision making comes in. Unfortunately, fear is a very big factor for women, but what many physicians don't appreciate, or rather, even if they appreciate it, they have a hard time accepting, is that even women who are fully educated are anxious.
Yeah.
And so anxiety and fear of the future and fear of another diagnosis and having to go through all the same crap again, that is a very valid concern, right? And so in our practice, we're very quick to ask patients who come in why they've chosen a mastectomy, if they've been diagnosed with cancer, why, many women, especially in the US, more so than any other country in the world, many women choose for a mastectomy of the healthy breast too. So they'll have a diagnosis on one side and they'll want a mastectomy on both sides with reconstruction. That's another thing that doesn't sit well with the medical community on the whole, because that's seen as uber invasive, right? Why are you removing a perfectly healthy breast? And we're very, very clear in discussing that and explaining that there is no survival benefit. But, most of the time, probably 90% of the time, 95% maybe, patients say, okay, I get it, doc. I'm not going to live longer, but I don't care.
And you know what's interesting? I don't remember my doctors explaining that there was no survival benefit. I don't remember my doctors explaining like you can still have a recurrence even though you've had a mastectomy. Mm-hmm. And for me, it was the logic like, I don't want to go through this again. And I know Dr. Love in San Antonio, one of the things that she said was it's like cutting off both hands because one did you wrong, but I really think it's hard to gain trust with your body after you've gone through something, especially for women that were young and they kind of defeat the odds and they were diagnosed with breast cancer, and also women that were very healthy when they were diagnosed with breast cancer. So,
yeah, well, it's a very difficult thing to understand, right, and to come to terms with. How can it be, how can you blame a lady who's in her 30s or early 40s, who's got no family history of breast cancer, she's testing negative for the gene, she's healthy, she works out. I mean, we've had triathletes in that situation.
Absolutely.
And she comes in and she's like, why did I get this? Well, multiple potential reasons. Is, environmental, a genetic component. All disease tends to be genetic in one way or another, even though there's no gene mutation to test for it. Why don't all smokers develop lung cancer? Well, right, it's some people's genes enable the body to be a little bit more protective, against lung cancer than other people, right? So, hey, baby. So this is one of 3 women in my life. Say
nice.
Hi. Hi.
Hello.
Sorry. So, how do you explain to that lady that, mastectomy is overkill, or, even a bilateral
Exactly.
mastectomy? It's like, well, okay, I get it, low risk, but here I am, doc.
Right.
And and when you look at the data and you use general numbers, and it's a bit muddy because there are lots of different subtypes of breast cancer, and there's a lot that goes into a percentage risk of future disease. But if you've had one diagnosis, then it's fair to say that you've got a 0.5% chance of getting a recurrence every year, or getting another cancer every year. So, if you're young and you do the math, then, you're looking at up to a 20% lifetime risk. That it's not 0.5% every year until, forever. It does kind of peak at 15 to 20% lifetime risk. But, for some people, that's a big risk that they can reduce.
Right.
So, it's not just about survival,
Right.
and 5-year survival data, 10-year survival data. It goes well beyond that. And then you've also got things like cosmesis, how things look after surgery. Sometimes really it's disingenuous. It's just not being honest when you've got a B cup breast, and you tell the lady that a lumpectomy, and they're going to save their breast, and then they get radiation, and then that shrinks the remaining tissue, and everything contracts, and now they've got this big hollowing. And they come into us and they say, they told me I was going to save my breast. This looks nothing like my breast.
Right.
Whereas breast conservation in a lady who's got, large D cup pendulous breast, that's a completely different situation. And that's from a cosmetic standpoint, she can have a great result and look like she's never had anything done. So, I think as surgeons collectively, we haven't done a good job in being completely honest with looking at the big picture. I don't think it's from a position of malice. It's not done on purpose. I just think everyone is so focused on a priority, right?
Yeah.
The priority is treating the ladies and the men. Men get breast cancer too, as you know.
Right.
But treating everyone and getting them through. But unfortunately, we're all stuck in our bubble. And we don't think about what the future holds for these folks once they've made the decision, and the consequences of those decisions. And doesn't matter how old you are, for some women, breast symmetry is a big deal, and the cosmetic outcome is a very big deal. And you have to respect that. So.
And what's interesting? I think that, there are a lot of women that feel guilty that they care about how their breasts are going to look after reconstruction or after a breast surgery. And I don't think women should feel guilty about that at all. I mean, it's basically like an amputation, that's a part of your body that is gone, and our bodies, that's how people see us in the world, that's how people perceive us. So I don't think women should feel any kind of guilt about caring about how their physical appearance is going to change after a breast surgery.
No, I couldn't agree more, but you're absolutely right. A lot of women feel that way. They feel they're being vain. I'm lucky to be here. What my word? It's like, well, the whole point of you being here is so that you can actually enjoy the life you're left with now.
Right.
Absolutely.
Right? So.
So after a woman has made the decision to go through a breast surgery, how does she decide if reconstruction is the right option? So going flat, a lot of women are doing that nowadays. Explanting, a lot of women are doing that. What kind of questions should a woman ask herself before she decides to go through reconstruction or forego reconstruction?
Yeah, I mean, just be honest with yourself, and what when you close your eyes and imagine looking at yourself in the mirror, what do you see? What do you want to see? Do you want to see something that's as close to what you have now before your surgery, if possible? Or, you know what, you just want to be done with everything and go flat? And, I mean, it's such a personal choice. Even the questions you ask yourself to arrive at that final decision are very personal. Right?
Absolutely.
So for some women, it's all about just symmetry. For some women, it's about the nipples. For some women, it's about sensation. So they're defined by their nipple areola sensation. I mean, the spectrum is huge. Right. It's absolutely huge. And what's equally huge in terms of spectrum is the physician response to what is important to that person. I've had phone calls from female medical oncologists apologizing for calling me because they have a man in their office who's had a mastectomy, and I can't believe this guy is concerned and he's got his battle wound, but he really wants a nipple. That's not even something you do, is it? Surely, it's like, well, no, of course it is. Of course we do that. Send them over, and that is, so that's discrimination too, right? What's the difference? There's no difference. So patients need to advocate for themselves, and if you're not being engaged in the conversation you want to have, and you're not if you're not talking about the topics that are important to you, by definition, you're not in a shared decision-making process, and you need to look elsewhere. Right? So shared decision-making means that you get to discuss and include in the conversation what's important to you.
Absolutely.
Right?
Yeah, I definitely always tell, other women that ask, or even just myself working in healthcare, letting people know, like, go get a second opinion if you need a second opinion. And if you're not being listened to, then, like you said, just leave. You can always find another doctor. Like, you should definitely be a part of the process, and any questions that you have should definitely be answered all the time.
Yeah, and then sometimes it just takes being completely blunt and saying, hey, doc, I'm really sorry. I know you don't have much time. I know you feel like you're rushed. I know you've got a bazillion people outside in the waiting room, but I need to have a deeper conversation with you because I don't feel like we're connecting right now.
Right.
I mean, mind blown, right? I mean, you gotta have that conversation. You got to say stuff like that.
Right.
If a patient is trying to decide between a lumpectomy and a mastectomy because nipple sensation is the be-all and end-all of her relationship with her spouse, you have to respect that. Right? So other women haven't had nipple sensation since they breastfed and they couldn't care less.
Right.
For some women, it's a massive deal. So the direction of the options that you present has to take that into account. And then you've got the other extreme where you've got patients that are invited to express their preferences, and they say, doc, you know what, just tell me what you think I should do. But that in and of itself, the invitation to the patient to define the level of autonomy that they want,
absolutely,
is in and of itself shared decision making, and that's what people don't understand about it. So
that is a great segue, because one of our questions is going flat is a perfectly acceptable choice for someone that is going through a mastectomy or bilateral or unilateral, whatever the case is. Going flat is perfectly acceptable, but it's not always offered. So what advice would you give women who have doctors that are pushing back on that decision? I've seen stories about women who wake up and they realize they've been left extra skin just in case. That's what they're being told, just in case they decide to change their minds. But how should women have those conversations? What advice would you give?
So the Justin, oh, I didn't heed what you said, and you're being emotional. And just in case you change your mind, because who doesn't want breast reconstruction? I left you extra skin. That's not cool. I do want to say one thing about surgical technique because it's important. Sometimes a surgeon can really, really try to leave you flat, but optimizing your contour at that first stage and leaving you without any excess tissue is not because they felt they had to, but it was a concern over blood supply to the remaining skin. If they're too aggressive with pulling it flat and not leaving any excess, if there's too much tension, you can convert skin that would have been okay to an area of necrosis. So I do understand and I appreciate that there is a lot out there. There's a ton of instances where the surgeon just didn't listen and they belittled the decision the patient made to go flat. I completely accept that. All I'm saying is that there are some times that things don't work out.
That's a really good point.
And so, I see, when someone wants to, so in my practice, if we get a phone call from a lady who wanted to go flat and didn't have an optimal result, guess who they see? They see me, right?
Right.
There are things that we do for plastic surgery techniques that we can do to correct issues, removing extra skin or dog ears that was left behind, whether it was on purpose or by mistake, or the surgeon didn't know the techniques to use, or they were worried about blood supply. There's fat grafting to fill in contour issues to make everything nicer and smoother. But I got to tell you, I've had patients back that I wasn't happy with the contour, and I thought I left that surgery. I remember it completely, very well. I was so happy with how it went, and then you see the patient back, and you say, "What?" It's like, but then things relax.
Yeah.
Scarring sets in. You get adhesions. You get all sorts of things, and then the contour isn't what it needs to be, and then you got to try and fix it. But anyway, it's just something to bear in mind. There are times when doctors aren't listening, but sometimes they are.
Yeah,
that's a great point. So, if someone decides to do reconstruction, what kind of options do they have? I know that there are like some standard procedures that everyone knows, but technology is advancing all the time.
Yeah. So, implants are the most common. 80% of reconstructions are performed with breast implants worldwide, I would say. You can get a very nice reconstruction with implants. Implants are a better option for someone who isn't so concerned about a natural look, wants to maybe look a little bit more enhanced. It's an absolute mistake to pick implants because, this sucks. I've got this diagnosis now and I always wanted a boob job, so I'm just going to go for it now. Because breast reconstruction with implants is not a boob job.
Completely different.
Yeah, completely different. Even small-breasted women have a little bit of tissue to cover the implants. Breast reconstruction patients after a mastectomy, they don't have anywhere near the same amount of tissue. And so there's a much bigger problem with being able to see the implants through the tissue that's left behind. Rippling, which is little waves that you see in the shell. It can look like a bag of worms sometimes, especially if you don't use gummy bear implants, which are really thick silicone. Implant reconstructions are cold to the touch, usually. Oh, I'm sorry, that's marketers. Sorry. So, that's one of the biggest misconceptions. And it's also one of the biggest things that women are told, from a position of love. Girlfriends will tell someone who's newly diagnosed, "Oh, well, look at the bright side. At least now you get the boob job you always wanted," which is like, oh, dude, you've got no idea. So please don't say that to your friends who've just been diagnosed. It's nothing like a boob job. And just to put things in perspective, I can probably count the number of women who look like they've had breast augmentation. I can probably count them on 2 hands.
Mm-hmm.
Wow. Yeah.
So the ones that you put in a presentation of your absolute best results that you could put, that people think they had a cosmetic procedure. Yeah, that's a very, very low percentage. And a lot of that actually is determined by your breast surgeon, because you need a very high quality mastectomy to get a really nice result with an implant reconstruction. So when you're looking for your breast reconstruction surgeon, make sure you pick the team, not just the plastic surgeon.
That is a great point. That is an awesome point.
Yeah. So, and then, women have to ask, are you there with the breast surgeon when he does the mastectomy, or do you just come in after they're done? Don't lead the question. Don't lead the answer. And if they say, "Oh yeah, we just leave them to their own devices. We stay out of each other's way." Oh, really? Okay. So how many mastectomies do you do in conjunction with this breast surgeon? You can get to the bottom of it unless they work together all the time, just be careful, because plastic surgeons get all the glory, but breast surgeons do all the damage.
Right.
I don't say that to be mean, but we're very proud of the results we get at PRMA, but our breast surgeons don't get enough credit.
Mm-hmm.
They think that we're blowing smoke. Patients think we're just being humble and nice, but it's true. It's so true.
Yeah.
They set the stage. Tissue reconstruction, which is the alternative to implants, you can use tissue from different parts of your body. That's more forgiving because you're replacing tissue that's removed with skin and fat from another part of your body, sometimes muscle, depending on the procedure that you pick. Mm-hmm. In the bio you read out, that was a good bio. Did I make that up? Did I say that? It's really good. But so you mentioned perforator flap reconstruction. Well, perforator flaps are tissue that's taken from another part of the body that is just skin and fat and the blood vessel that tissue needs to survive. And oftentimes that blood vessel travels through the muscle. The best example, really, for people to let people know about is the tram flap. It's a old procedure. It's performed today. It's kind of a workhorse of reconstruction. We've moved away from it though because it sacrifices your abdominal muscle. Mm-hmm. And if you're reconstructing one breast, then you take your core muscle strength, your core strength takes a hit because that tissue with the tram flap is fed by blood vessels that travel through the muscle, and so the muscle is sacrificed in order to maintain the blood supply to the tissue, and that the tissue is tunneled up under the upper abdominal skin. So the tram flap uses the lower abdominal skin below the belly button, and then you dissect it, prepare it, and tunnel it under the upper abdominal skin into the breast area. And then the muscle is just folded up on itself, essentially. And so the blood vessels are traveling through the muscle to supply this tissue that's the new breast. But now you've sacrificed one of your six-pack muscles, which for some women, they notice. The bigger problem is when you're reconstructing both breasts and now you've taken out both abdominal muscles, and that's a big hit. Mm-hmm. So the procedure evolved, and so now we have a perforator flap procedure that really has replaced the tram flap at centers of excellence, and that's called the DIEP flap or DEEP flap. Or DIEP flap in Europe. So what that does is it uses the same skin and fat of the lower abdomen, but instead of sacrificing the muscle, the procedure finds the best blood vessel or a couple of blood vessels and plucks them out from within the muscle fibers and leaves the intact muscle behind. It's also very important to maintain the nerves that power the muscle so that you don't lose tone. So that's an example of a perforator flap. Those little blood vessels that travel through the muscle into the overlying skin and fat, they perforate through the muscle. So that's why it's called a perforator flap. So there are lots of different types of perforator flaps. The DIEP is just one example. We can use tissue from the thigh, tissue from the buttocks. There are lots of places you can take it from.
Yeah, and I know that a lot of women, that's what we're hearing a lot online now, is a lot of women doing the deep flap procedure, which seems to become more popular. And that kind of leads us into definitely, our next question with, doing surgery and cutting on darker skinned women. One of the questions that was asked is, since people of color tend to keloid with surgery, like myself, any type of minor type of cuts that I get, I will automatically get a keloid. Which, for people that don't know about that, a keloid is basically like built up scar tissue. So since people of color tend to keloid with surgery, what questions should I be asking my surgeon to hopefully prevent from this happening? Should I be looking for a plastic surgeon who is more familiar with, brown or melanated skin?
Not really. All plastic surgeons should know about hypertrophic scars and keloids. So people tend to refer, or patients tend to refer to all ugly scarring as keloiding. There's a difference actually between a true keloid and a hypertrophic scar. If a scar is, raised, thick, darker, on lighter skin tone folks, the scar is more red. On darker skin tone folks, the scar tends to be even darker, more pigmented. But if it's still, a line and it's just a really, really thick scar that's like a rope, then that's a hypertrophic scar. A keloid grows beyond the initial injury to the skin. So you end up having these mounds of scar that it spreads like a tumor, actually.
Right.
So those are even harder to deal with. All plastic surgeons are familiar with techniques. They should be. We're all trained in that in residency. There are techniques you can use to decrease the risk of scarring in that way. All surgery causes scars. All scars are permanent. But there are things we can do to decrease the risk of hypertrophic scarring and keloiding. Interestingly, if you've had radiation, you're probably not going to get a hypertrophic scar on that breast or a keloid, because actually it's one of the treatments of radiation. You just get pre-treated. And so radiated skin doesn't keloid or hypertrophy like non-radiated skin. Okay. But there are injections we can do, steroids, silicone sheets we can use prophylactically very, very early on. Scar treatments, all sorts of things that we can try and use to minimize the risk.
Okay. Now, we're going to talk about lumpectomies for a little bit. I opted for a lumpectomy instead of doing a mastectomy. That was just a personal choice of mine after talking with all my doctors. So one of the questions that was submitted to us was, having a lumpectomy doesn't guarantee women won't have to have revision surgeries, as many women do after a mastectomy, but women can spend years in and out of operating rooms trying to get the perfect look. Is there such a thing as too many revisions, and are there risks associated with multiple breast surgeries? Like I said, for myself, I had a lumpectomy and I had 2 revisions afterwards. So I can definitely relate to this question. I think when people hear that a woman's had a lumpectomy, they just think that that's it and they're done. They don't have to have any other surgeries after that. But I mean, even right now, I should probably go have another surgery, but I'm done. I'm tired of having surgeries like a lot of women are. So how would you answer that question for us, Dr. C?
So prevention is always better than treatment, right? So you're far better off trying to prevent issues of symmetry and issues of contour, deformities. And the way to do that is, have the right conversation before the lumpectomy. There's, oncoplastic surgery is an option that is like a lot of the breast reconstruction techniques that aren't offered because the plastic surgeons don't offer them. That's the number one reason. Why wasn't I taught about this? Well, because your guy doesn't do it. Oncoplastic surgery.
I mean, like, really, I got that response. Like, I felt really attached to my doctor. So then I felt like I needed to make the decision that would allow me to stick with her.
Mm-hmm.
Yeah. No, I mean, that's honestly, that's got to be the number one reason. I mean, especially in a fee-for-service industry, so if you're a good deep flap candidate, number one, a lot of surgeons don't appreciate who a good deep flap candidate is, because if you've had a surgery or two, they think you're not a candidate, or they look at your belly, and if you don't have a lot, they think, oh no, you're too thin. In reality, both are candidates. You've just got to have the expertise, and then they push you towards getting an expander, right? So, oh no, you're not a candidate for this. You should have an expander. Well, do you do anything else but expanders? No, not really. Or maybe a latissimus flap from the back or something. But you look at oncoplastic procedures for ladies who choose to have lumpectomies, and that's the same problem because, well, first of all, what's oncoplastic? Oncoplastic means that you have a lumpectomy using plastic surgery techniques in conjunction with the lumpectomy. So the lumpectomy is performed whilst you have a simultaneous breast lift or breast reduction. Mm-hmm. And the reduction or lift, the scar pattern is designed in a way that will enable the breast surgeon to do the lumpectomy that they need to do. Again, it's prioritizing the cancer treatment. Mm-hmm. And then that way you have a breast reduction at the same time as your lumpectomy or a breast lift, and you have the symmetry procedure done on the other side. And then you have, as close symmetry as you can get. We actually tend to leave the breast that's going to be radiated. I tend to leave that a little bit bigger because radiation shrinks tissues a little bit. So you tend to let that kind of, if a lady needs a reduction or wants a reduction as part of this, then we'll reduce the healthy breast to where we want it. And then we'll reduce the lumpectomy breast a little bit less, so it's a little bit bigger, and then the radiation kind of shrinks it, and then you have a better chance of getting some symmetry. So we tend to leave it about 20% bigger than you want it.
Okay.
But only 10% of breast surgeons in the US offer oncoplastic surgery. Yeah. So most of the lumpectomy patients we see are the ones who are unhappy, who didn't know anything about oncoplastic surgery. Mm-hmm. So, well, doc, I was a double D. I was looking at a breast reduction, and then I got this diagnosis. And so, you mean I could have actually had it after all, and at the same time? Yeah. Well, why didn't they tell me about it? Because they don't do it. So now after the fact, all right, let's get on with it. You can't control it. Let's move on.
Right.
After the fact, the number one option we have for addressing lumpectomy contour issues is fat grafting. That involves liposuction from another part of the body, wherever you've got some fat, and then that fat is purified. And then we re-inject it into the area after releasing all the scar tissue in the area, so that the scar tissue prevents the skin from opening back up and filling up. So you've got to release all the scar tissue so that when you inject the fat, things expand again. The problem with fat grafting is that between 30% and 50% gets reabsorbed. So it's, you got to be prepared to have more than one fat grafting procedure.
Now, Dr. Can you, for someone that already has implants, And let's say they just don't want implants, but they still want to have breast mounds. Is fat grafting an option for them? Or do they have any other options after they've gotten implants?
Yeah, you can switch to tissue. You can add fat on top of your implant. You can stick with implants, add fat on top to add volume, to try and make them feel a little bit more natural, look a little bit more natural. So that's one option. The other option is to remove everything and go flat. And then the other option is to stick with reconstruction, but take out your implants, take out the scar tissue around it, and just have a flat procedure, and just convert your, do an exchange of the implants for tissue from another part of your body. So yeah, it's not, you're not burning any bridges if you go with implants. And that's another reason why some women choose implants initially. It's like, recovery's shorter, it's a quicker surgery, I don't have to worry about a scar, another part of my body, I'll just go with implants. And then things don't work out, but they didn't burn any bridges.
Right.
So, you can always go back and do tissue. Just because you've had implants doesn't mean you're stuck with them if you're unhappy or if you've had problems.
And so I'm guessing that's the same because another question that we had is, I guess it's the same for a woman if she decides to go flat at first and she just wants to delay reconstruction. Is there a time limit that she can?
No, there's no time limit. Insurance covers it. There's a federal mandate to cover reconstruction if the mastectomy was deemed medically necessary.
Okay.
Which, of course, for breast cancer, it is medically necessary in those ladies.
Right.
So there's no time limit. If you decide that you want to go flat and then you have decisional regret and then you want reconstruction afterwards, decisional regret can happen with any decision you make, right? That's life. You're in a different emotional state.
Right.
Once the cancer treatment's done, some people start looking at things a little bit differently, and that's absolutely okay. And you can't give yourself a hard time if that happens. It's okay.
Right.
So you can have reconstruction after going flat. The only issue with that is that the cosmetic result isn't as nice as if you had breast reconstruction at the same time as your mastectomy. So delayed reconstruction, you have more obvious scarring, and you're not going to have the opportunity like you did if you had immediate reconstruction at the same time as your mastectomy. You're not going to have the opportunity to potentially look like someone who's had a cosmetic procedure, right? So, but there's a lot more to the decision making than just scarring, right? So for some women, that it's not that big a deal in terms of the main factor. Right. And going back to your lumpectomy question, is it can you have too many surgeries? Well, you got to ask yourself, why are you wanting more surgery, right? So if it's really egregious, if you look at yourself and you're like, man, I can't even wear a bra. This is, I've got a cup and a half difference. This is ridiculous. I can't, my bras keep shifting. I can't wear a bathing suit. I can't be with my husband with the lights on, whatever.
Right.
Then you have an issue because it's a major impact on your quality of life. If you're looking down at yourself in a bathing suit and one breast looks a little bit fuller in this little area here than the other one, then you got to reset your expectations.
Yeah.
Right. Mm-hmm.
Right? And so, and doctors, we struggle with that because we want to make everyone happy. And sometimes the last thing you want to hear is that you got to reset expectations.
Right.
And then the other issue is, when you look at the whole breast cancer diagnosis and what comes with it, that person hasn't had much control of anything. Mm-hmm. So all of a sudden, they have control over something.
Right.
Right. And so that's a big deal for them. I remember this was about 10 years ago now, 12 maybe. So I was more arrogant. I hadn't had all the hard knocks as a surgeon. I thought I was the bomb, and I'm a lot grayer. I have less hair, and I've been married for almost 20 years, so I'm fixed now.
Right.
So I remember asking the lady if I could, open up her gown to look at her after her surgery, to evaluate her and make sure everything was okay. And I opened up her gown, and inside my head, I said to myself, "Dang, she looks awesome. She looks great." And then she says, "Now, Doc, I know you can't see this from where you're sitting." So that was a red flag, right? "I know you can't see this from where you're sitting, but when I look down, I see a little bit of extra fullness on this one breast compared to the other side, just in this little one spot here." And she's pointing to it. And, I was immature. I didn't get it. I was like, what? I thought to myself, it's like, what more do you want from me? This is a home run. I wish everyone looked like this.
Mm-hmm.
But then I realized, she wasn't trying to be difficult. She wasn't being vindictive. It wasn't that she wasn't appreciative. It was the fact that it was the first time she could actually control anything in the conversation.
Right.
So ask yourself, why do I think I need more surgery?
Mm-hmm. Okay.
And that's really crucial in deciding whether you really should have surgery or not.
Right. Now, Jasmine, you had a mastectomy. So how did you make the decision to do a bilateral mastectomy versus a unilateral mastectomy?
Well, for me, I was a triple D. And so much of my breast was affected by the cancer that I knew there was no way they were going to be able to do a lumpectomy. Like, it wasn't even an option. So really the only option I had was to take one or to take both. And I mean, initially my thought was that it would maybe be less surgery if I went ahead and did both. And I also did not understand, if I'm honest, I thought that if I removed both of my breasts, then I wouldn't have to worry about getting another recurrence. I thought that was like a preventative measure. And it wasn't really until I was diagnosed in 2016, my mastectomy in 2017. It wasn't really until last year that going through all these advocacy trainings that I really understood, like, oh, that really didn't do anything. But I will say that after I did proton therapy radiation, and proton therapy radiation does much better on the internal organs, but it does a lot of damage to the outside of skin. And that basically, I was nice and full after my mastectomy, nowhere near triple D, but I was nice and full, and I shrunk down to like a B. I'm like a B now. So it shrunk a lot. Mm-hmm. And I knew that there was really not going to be a way for them to match my natural breast size. Not that I want to match that big. But for me, that was a large part of it. I was under the impression that it was a preventative measure. And I really didn't want to have to go through a lot of balancing. So I have not gone back for my revision. I was supposed to go back for my revision. I really can't even. It's almost traumatizing having to go through all those surgery. I really can't put myself in a mental space to do it as an option. Like, last time I didn't have a choice. I'm having a hard time choosing to go back through it.
Right. Now, see, that's what's funny about that is I remember when I had my appointment with my oncologist, and I did two. I had a second opinion, and they both said that I should get a mastectomy. And the doctor that I actually work with, I was talking to him about it, and I'm just like, I don't want to do a mastectomy. I want to have a lumpectomy, but they're telling me that I need to have this. And he said, you need to go back to them and ask them, if you got a mastectomy, would that mean that you don't have to do chemo? And if you don't have to do chemo, then I would say go for it. But if you still have to do chemo, then why would you cut off both of your breasts? And I went back and asked both of them that, and they were like, no, your cancer's too aggressive. You're still going to have to do, chemo, regardless of what surgery option you choose. And I'm like, well, then why would I have a mastectomy? Then it doesn't make sense to me. So, it's just, that's where it's like the shared decision making comes into play, because you should have physicians or everybody that's on your cancer care team that is giving you that, information. So you could be like, okay, let me process this and then come back and make my decision from that point.
Yeah, whereas, so the chemotherapy isn't determined by the lumpectomy or mastectomy. So you're absolutely right. That's a common misconception. If I have a mastectomy, I won't need chemo. But radiation is a different story, because most women will avoid radiation if they choose a mastectomy. And some women just don't want the issues of radiation. Radiation has come a very long way. It's improved significantly, but unfortunately, we're still left with, everyone reacts to it differently, and you can have complications from it. It's not benign. There are issues associated with all breast cancer treatment. Radiation is no different.
Mm-hmm.
And what's ironic is we talk about how aggressive some of the surgical options are, and mastectomy is so aggressive, and this, that, and the other, but yet we radiate people left, right, and center like that's not aggressive.
Mm-hmm.
It's like, really? That's not aggressive? You can get lung issues, heart issues, and that's not aggressive?
Mm-hmm.
I'm not saying you shouldn't have it, but I'm just saying, just like we shouldn't minimize potential complications of surgery, and I think sometimes we don't discuss potential complications enough as surgeons. Mm-hmm. But being completely forthright and transparent about the potential complications of radiation is also something we need to be doing. And sometimes I feel that that's really under discussed. And again, it's not a position of malice. It's not the radiation oncologist trying to sell anything to the patient. I really don't believe that is the case. I think it's just they don't appreciate that the other issues that come along with it. We go to breast cancer conference as a practice every month, and we talk about the same stuff all the time. It's like Groundhog Day. It's like it's like, yes, radiation does impact your reconstruction. It can, right, significantly, right? So, you can get other issues, but anyway, it's all info.
So before we move on, I want to give, we have the questions coming in. We're actually getting ready to move towards the viewer questions. Dante just asks, does the federal mandate apply to patients on Medicare as well for breast reconstruction?
Yes.
Mm-hmm.
And also, Natalia, actually, she said that she thought it was a great point when you said that we should be picking our doctors in teams. And someone else, Keisha, said that she actually did that. And let's bring that comment back up. She said that she chose the team, and both surgeons worked together and attended the surgery. And this was an option it's a way to advocate for yourself, which I think is a great point.
Mm-hmm.
And these conversations are so important is because I didn't know that I was even a thing. I didn't know that you should be thinking that way when you're choosing your doctors. So for other women, I think it's great to hear that you have a choice. You don't have to get the randomized doctors. You can work with doctors that are used to working together.
Right.
Yeah. And actually, we're even seeing that in patients that are choosing to travel for their surgery. In our practice, we get a lot of people traveling to us for specific procedures that they don't have access to where they live. And that communication is important there too, because the local breast surgeon, just because the patient isn't getting breast reconstruction there, the local breast surgeon needs to know that that patient is planning breast reconstruction, because what they do is probably going to be different. What they leave the patient with in terms of skin, etc., like we've already touched upon, it's going to be different, and they have an impact on the final result. So that communication really, it's probably the one thing that humans are the worst at, communicating.
Yeah, we could say that in a lot of different instances.
Yeah. So unfortunately, patients need to make sure that that's happening.
Yeah.
So our last viewer question, and if you guys have any questions after this segment, we'll do our best to get them answered. I know there were some submitted questions that we didn't get to, but we will work on getting answers to those before we move on to our next segment. But Keisha said that she had 2 surgeries. She had one that was for the removal of the tumors, then a week later, reconstruction, and her friend was able to do the surgeries in one day. Do you have any inclination on why that would happen?
So, yeah, lots of reasons, potentially. Some it's an access issue to plastic surgeons. You can be in the same in one city, but if your breast surgeon is in one system and your plastic surgeon is in another system, the logistics of it determine the staging approach. More commonly, though, it's because we're concerned that the patient's going to need radiation. And you can have reconstruction at the same time as mastectomy, even if radiation is planned after the mastectomy. But that increases the risk of issues because the radiation can really negatively impact your reconstruction. So even though it's possible, most plastic surgeons recommend that you delay the reconstruction until all your treatment is done.
That's what I did.
So that's one reason. That's radiation. Again, advocating for yourself is crucial. There are set protocols that radiation oncologists use, but a lot of it is up to their own kind of assessment and determination. Some use breast reconstruction friendly techniques that decrease the risk of impacting the reconstruction or minimize the impact while still prioritizing cancer care, which is always a top priority, as we've said several times. And other radiation oncologists really just ignore the reconstruction and just do the same thing for everyone. When you're practicing an evidence-based approach, there are certain things that we know you can adjust without impacting cancer care. And there are other things that we're not sure yet. So the things you're not sure about, you have to keep doing. But the things that you can dial back on without negatively impacting cancer care, why wouldn't you do that? Well, absolutely. So, because you get to, if this is optimal treatment, and then above this line, all you get is complications and no benefit in treatment, then why would you treat someone here when you get the same cancer care here? Does that make sense?
Absolutely.
So again, you got to advocate for yourself, but it goes beyond just the surgeon.
Well, thank you so much, Dr. C. We've enjoyed talking to you tonight. Guys, if you have any more questions, we're happy to send them to Dr. C, and I'm sure he'd love to answer them with you. Dr. C, we appreciate your time.
Thank you so much.
We hope you have a great evening, and we'll see you soon.
Sounds good. Thanks, ladies.
Bye. Have a good night.